Let's get started. Thank you, everyone, for your patience. Appreciate it. Just have to work out a few technical glitches, but we are good to go now. It's the magic of doing this live, which is very exciting. So thank you for being here. We have a great presentation today, PTSD and ovarian cancer with Dr. Stephanie Tung, who's a psychiatrist at Dana-Farber, and Anna Walters, who is a GYN oncology social worker, also at Dana-Farber. So we are going to just jump right into it. If we have time for questions at the end, we may or may not, but if we do, the presenters will be happy to take them. So you can just put them into the chat, and if we can, we'll get to them later. Thank you.
All right. Well, thank you everyone for attending. As mentioned, so I'm Stephanie Tung. I'm a psychiatrist at Dana-Farber. I have a background in women's mental health and very interested in medical education as well. And so thank you for inviting us to present at this conference. Okay, so I'm gonna, oh, Anna, did you want to introduce yourself?
Yeah, my name is Anna Walters. I'm an oncology social worker at Dana-Farber Cancer Institute, and I specialize in working with gynecological cancer patients across diagnoses. Thank you for having us.
All right. So we're going to start out just talking about PTSD in general, just kind of in the general population. This is something that occurs kind of worldwide, the lifetime prevalence, so that kind of the chance that this occurs within someone's life is about 7.8%, kind of the lifetime prevalence. And then in the United States, the prevalence is about 3.5%. So kind of globally, the prevalence is higher than kind of within individuals in the US. The highest rates, though, do occur among women. And then we're going to talk a bit more about PTSD within ovarian cancer specifically. Before we do that, I wanted to provide just some context about what PTSD is and kind of how we think about it from a mental health perspective. So I'm going to talk about some of the diagnostic criteria and the manual. So on the next slide, the manual that we use within psychiatry from the American Psychiatric Association, we use this diagnostic and statistical manual. So the DSM, you've sometimes heard of it referred to. And there are different editions of this. So currently we're on the 5th edition. And here are some of the criteria that we think about when we think about PTSD. So the first, and a lot of this, I just kind of put up here for your reference. We're not going to go through all of the slides in detail, but just so that you have this for your own knowledge as well. So when we think of PTSD, in general, there has to be some type of exposure to a type of trauma, and it can either be something that has actually occurred to the person themselves, or it can be something that occurred to somebody that they know or someone that they've heard of, usually somebody who's close to the person as well. And so we'll talk a little bit more about what some of the specific traumas are as they relate to ovarian cancer, but just in general, to know that there has to be some type of traumatic event associated with the symptoms. And then for the next slide, so there are usually some type of intrusive symptoms as well. So in addition to having an event, there have to be some symptoms that occur following the event. The common ones that we think about when we think about PTSD are things like nightmares, flashbacks, feeling like you're reliving the event. And these can be, intense triggers related to the trauma that can produce a variety of physiological responses and emotional responses. So for the next slide, in addition to having some of those classic symptoms, another very common symptom is that a lot of individuals with PTSD do also experience avoidance. And so this can lead to people feeling very isolated or withdrawn. Basically, the avoidance is due to kind of the intense response to the trigger. This can lead to people avoiding reminders of things that, things that bring back memories of the trauma itself, or things that cause the person to think about or re-experience the trauma. That, naturally people would want to try to avoid these things, but over time that can lead to people, avoiding more and more things or more and more people, and can cause people to feel a bit closed off or isolated as well. So in terms of, the next slide, in addition to those kind of core symptoms, there can also be a lot of negative symptoms related to cognition, so kind of how people think about things, as well as mood. So kind of your emotional reaction to things. It can be associated with things like depression, with things like anxiety as well. And it can also be associated with some negative thoughts about just kind of the world or about people in general. If people have been hurt or experienced really frightening and scary things, it can be hard, to kind of function and to trust people and to, place themselves in a situation where they are afraid they may experience similar experiences as well. So the next slide, so there can also be some changes in terms of arousal or reactivity. So when we think about PTSD, oftentimes, individuals with PTSD will describe hypervigilance, so feeling like you're really on edge, worried that something else is going to happen to you, or they can experience an exaggerated startle response, so feeling like, if they hear something or see something that reminds them of the event, that'll cause them to kind of jump or kind of feel like they're crawling out of their skin, feel like there's a heightened physiological response to the trigger as well. It can also be associated with changes in sleep. So a lot of folks with PTSD will say, I have trouble sleeping through the night, or I have difficulty falling asleep, or like a small noise in the night will wake me up and I have trouble going back to sleep. And then also can lead to problems with concentration, so difficulty focusing, difficulty accomplishing tasks. In some individuals, there can be, really extreme behaviors or extreme outbursts or anger or irritability. And this could be something that, the person will very easily, describe, I feel like I reacted in a, extreme way to something that I normally wouldn't have. And they can kind of lash out or, behave in ways that they wouldn't otherwise behave prior to the trauma. It can also lead to some reckless or self-destructive behaviors, which can, be harmful in the long run as well. So the next criteria are related to kind of the time and the impact. So in terms of timing, in order to meet criteria for PTSD, the symptoms have to occur for more than 1 month. And they also have to cause clinically significant distress or impairment in functioning. And so, if we think about these criteria, a lot more people are going to experience PTSD symptoms, but may not meet full PTSD criteria. So they may not have the full disorder, but they may have PTSD symptoms. So as we think about this going forward, I think Anna and I wanted to talk about, define PTSD very clearly so that we know what that is, from a mental health perspective. But we also wanted to talk about just kind of trauma responses in general, as they relate to cancer and ovarian cancer specifically. So we're looking at this really with a trauma-related lens, but also thinking about, when these symptoms do cluster together and when they do cause significant distress, they can result in the full disorder, the full PTSD criteria being met. So in a smaller subset of patients will experience full criteria for PTSD, and then a larger proportion will experience some symptoms throughout their life. Okay, so with the next slide, these are some just kind of more fine point kind of criteria or kind of add-on criteria that we can add when we think about PTSD. And so sometimes if you talk to folks who have experienced trauma, they may describe some of these symptoms. So just so that you're familiar with these, some individuals with PTSD will describe feeling a depersonalization, so feeling like they're actually detached from or outside of their body looking in, feeling like, they're a bit disconnected from the reality. And so there can also be a derealization, feeling like they're having difficulty telling between what is real and what's not real. And so sometimes this can be mistaken for kind of like a psychosis picture. But if you ask them further, a lot of it actually relates to the trauma and the traumatic experiences. So folks can say, I feel like when I see things or when I experience a trigger that reminds me of the trauma, then I either feel like I'm outside of my body looking in, or I feel like I'm in a dreamlike state and I'm not sure what's real and what's not. And those would be PTSD related symptoms. Okay. So the next slide. So in terms of thinking about PTSD in general, this does tend to be a more chronic disease. In general, compared to other diagnoses, like major depressive disorder or generalized anxiety disorder, PTSD does not respond as well to psychiatric medications or kind of pharmacological therapies. It does respond very well to just psychotherapies in general or counseling approaches, mindfulness. And so we'll talk a lot more about that when we get to kind of the treatment approaches, but just something to keep in mind for PTSD in general. In addition, individuals who do have PTSD are at increased risk for both medical, psychiatric illnesses, and increased risk of suicidal thoughts, as well as suicide. There can be significant impacts, as we discussed, on just work, social functioning, and also quality of life in general. So it can be a very distressing illness, and over time can have a significant impact on the individual and on their family and kind of social network as well. So we spoke about the prevalence of PTSD in the general population, so somewhere between kind of 3 to 7%, depending on where you are in the world and kind of the population. When we look at individuals with ovarian cancer in particular, there again, kind of the prevalence does vary a bit, but based on the studies that we do have, in some studies it's kind of as low as 0 to 26%, in others it's as high as 36 to 45%. And unfortunately, we're a bit limited in terms of the literature and kind of research and data that we have on ovarian cancer and PTSD within this population. And we'll talk a little bit more about why that is. But in general, it can be challenging to study PTSD. And one of the reasons for that is that avoidance is one of the key symptoms. And so because individuals with PTSD tend to avoid things that remind them of the traumas, and tend to be a little bit more isolated, those individuals may be less likely to engage in clinical care or research studies, and just may be less likely to interact with the healthcare system in general. And so most likely we are actually getting underestimates of the true prevalence within kind of individuals with PTSD in general as well. Okay.
Thanks so much, Stephanie. So that's a really great overview, like she mentioned, of the clinical criteria that mental health clinicians often use with which to sort of understand the spectrum of trauma and the criteria that folks might meet. And now that we've had an overview of what PTSD looks like from that diagnostic perspective, we wanted to provide some clinical context and really walk through how PTSD can arise within the traumatic experiences of ovarian cancer. So there are a number of traumatic experiences that can take place within a cancer diagnosis, and specifically within ovarian cancer. When we think of ovarian cancer in particular, it's well described as having few physical warning signs for patients, as well as limited screening methods for early stage disease detection. So as a result, symptoms can go unrecognized for longer periods of time than in other cancers. When they are realized, symptoms might be misattributed or discounted as being from a mental health origin or a GI cause, leading some ovarian cancer patients to be sitting with a sense that something is wrong, but I don't know why, or that their concerns aren't being taken seriously. So when patients present to us at Dana-Farber, there's often a really frustrating historical context in which they wish their gynecologist or primary care doctor had been more aggressive or widened the breadth of clinical testing to understand what happened sooner. And because of the delay for the various reasons it can happen, patients may be diagnosed at a later stage with more widespread disease, leading to feelings of helplessness, powerlessness, or questioning what could have been done differently. And so ovarian cancer is unique from other cancers in many ways. There's the piece of sort of individualized experiences of diagnosis, but also the medical and social context of ovarian cancer can inform the hardship that comes with diagnosis. It is less common than other cancers that women may experience, so for example, breast cancer. And as a result, that can lead to less social awareness of the impact on one's life. The minimal attention and fewer resources devoted to studying the impact of ovarian cancer, it certainly impacts the medical landscape in terms of treatments, but it also can definitely impact the mental health landscape of sort of what is known and what can be expected. And so it can lead patients to have feelings of isolation or feeling forgotten on a societal level, be it due to lack of representation across the lifespan, and also this can be reinforced within marginalized demographics. And then, the journeys can look as different as they do to diagnosis. Once a patient does get a diagnosis of ovarian cancer, a very sudden uncertainty can come up about the future. Gyn cancers have a wide perception of high mortality. They can be aggressive, whether it's with a poor survival rate or a high recurrence rate. Patients may have some knowledge when they get this diagnosis of what it means to have ovarian cancer, but I think even more might go on Google and kind of see what comes up and see things like a 5 to 10 year survival rate. And even though every case is different, this leads them to come to clinic asking some big questions like, what is going to happen to me? What does this mean for my life? And just the sheer kind of weight of the unknowns can be really, really hard to navigate. In this initial stage of diagnosis, a lot of patients have what we would call a fight or flight response. This can look a lot of different ways depending on the person. One side of the spectrum could be, your mind is in overdrive when you get the news of the diagnosis. You feel like you have to hit the ground running, or you're overwhelmed by thoughts of what to do next. And on the flip side of that, sometimes patients might find themselves feeling completely numb and disconnected from what's happening, or with an urge to sort of get away or separate from the situation at hand. Both of these are seen as a form of survival mode. And because of the overwhelmingness of the experiences, delayed processing is oftentimes something we see too, where patients may receive their diagnosis and actually complete entire rounds of treatment and move into surveillance. And only then, once they reach surveillance, do the feelings crash over them of just processing the loss, the anger, the frustration, all of it. And now being challenged to do so without the same medical structure that they had during treatment. Another piece that patients can notice is a heightened awareness going forward in their bodies. What does every ache and pain represent? That trust with the body can be disrupted. And the constant fear of recurrence can really permeate everything because, such a high number of patients do recur. It's a very valid fear. And so when we think more generally about not just experiences emotionally that can happen at diagnosis, but particularly traumatic aspects to it, a very intense emotional experience that comes up early in diagnosis, but also throughout treatment is that of loss and grief. That can happen on many levels. I think there's a component of loss and grief around autonomy due to sort of the loss of control over where their bodies are going during the day, what treatments they're being asked to do. It could be their schedules or even the structure of their lives. And that can really lead to a need to grieve for that sense of self. Another piece of grief absolutely that comes up is with the physical self. So patients often need to grieve the experience they used to have of their bodies as a place without pain or danger or fear. That can also look like changes in appearance. So for example, Taxol is still one of the frontline treatments used to treat ovarian cancer and very much associated with hair loss. And so it brings up this critical theme of identity, whether it's internal or external, themes of hair loss, if patients need a hysterectomy and the ability to birth children, or sexual health. All of these can be massive adjustments and big areas of sudden grief that come up. And on the third side, I think patients, socially, they may be used to holding roles in work or family, and really struggling with the role shift that comes up as a result of treatment. Kind of understanding, what does it mean to be a patient now, and how do I evolve my identity in the context of this? That can be further reinforced by grief around stages of life. So whether it's a young adult getting an ovarian cancer diagnosis or someone well into retirement, this feeling of this isn't the way my life was supposed to look. So with other challenges that we think of that come up as well, beyond just the kind of fear and worry of recurrence, when a recurrence actually does happen to patients, if they are going to get a recurrence of ovarian cancer, many patients do relapse in the first 2 years after initial diagnosis. That can lead to very significant distress, understandably. When they come back for that second line of treatment, there can be as many or even more questions as when they were first diagnosed about, how am I going to manage this, and will I ever be able to live a normal life again? And so a lot of the work we do with folks around reoccurrence, it focuses on sort of, what does it mean to live in the gray zone? What does it mean to live with the unknowns in a really concrete sense in the time ahead? Other challenges look like allergic reactions. Individuals can have a Taxol or carboplatin allergy, which can be a very scary experience to go through initially, as well as when they come back for future treatments, anxiety and trauma responses are heightened. So there's sort of the weighing of the question, what happens if I have another allergic reaction? How am I going to get through it? But also with the reality of, this is the medication that's keeping me alive. So it really puts people between a rock and a hard place. I think when it comes to associations in the medical environment in general can get so strong that, patients oftentimes will tell us that commutes themselves can start to feel triggering, whether it's a stressful drive, but also passing certain buildings or long trips. It represents the trauma of what's happening in a very visible and tangible way. And to the last piece about those visual reminders, I think places like waiting rooms, needles, even medication itself. So for example, Doxil is another very common medication we see our ovarian cancer patients receive. It's a bright red color. And so even just seeing that can remind folks of their initial symptoms or journey to diagnosis. And there are ways to sort of navigate these trauma responses as they come up during treatment, but that doesn't change them from being just incredibly distressing in the moment.
So I think thanks Anna for that excellent overview. And I think we've heard a bit about specifically the symptoms that occur in ovarian cancer. I just wanted to pull in a little bit more information from the literature, which, very much matches a lot of the patient experiences that we hear about in the clinic. That about 38% of individuals with cancer will report significant emotional distress, including PTSD, anxiety, and depression. The symptoms can be either intermittent, so kind of occur and then resolve, or they may sometimes persist after the treatments have completed. A lot of patients will experience kind of the classic symptoms, these intrusive thoughts or memories, as well as feeling the hyperarousal and feeling that there's often avoidance of certain triggers. They can experience the disrupted sleep, the weight loss, and this can definitely, if the symptoms are very severe, it can also affect the ability to adhere or comply with oncology treatment. So if there's really heightened response to triggers, or if, just coming into the clinic or driving into the clinic is very distressing, that can make it challenging to overcome some of those barriers. And so really important to identify these symptoms early and to get people into treatment.
And when we think of mental health screenings, but really asking that important question on, from the clinician side, how are PTSD symptoms caught by clinicians in order to be able to treat patients early on? Sometimes PTSD symptoms are captured through intakes or distress screenings, but more often than not, they are not captured through these surveys. People may very much feel and express that they are okay and they're getting through it, while at the same time having PTSD symptoms disrupt their lives. And so other forms of screening or diagnosis can come from providers like ourselves, noticing trends in patient lives and initiating conversations about that. And of course, there are absolutely times when patients might directly ask for support because they realize the symptoms that they're having and the degree to which it's distressing and impacting their lives. There can also be a lot of challenges in patients and providers discussing PTSD or traumatic symptoms due to the role of stigma that still exists, both around mental health in general, but certainly PTSD. Patients absolutely can have social messages sort of internalized, which in turn inform their internal expectations. So we hear things from patients like, my reaction isn't supposed to look like this, or this isn't what being strong looks like. And so there can be shame in sometimes realizing or recognizing that the traumatic effects very much have a human impact. Patients will sometimes self-identify as well as having traumatic experiences in their past, even before cancer, such as sexual trauma or abuse, but that doesn't always come up right away. And I would say from a clinician perspective, frequent indicators that can bring PTSD to mind as a clinician include that piece about the hypervigilance, noticing folks be on edge, really impactful trigger responses impacting their quality of life, the mood, behavioral, sleep disruptions, broad beliefs, and also that time period in particular of greater than 1 month when we think about the DSM version of a PTSD diagnosis.
And so looking at individuals with cancer, we know that definitely, there are certain risk factors related to having a very traumatic experience, either in the hospital, in the clinic, a reaction, an allergic reaction during treatment. But what are some other risk factors? So what might kind of place somebody at heightened risk of developing PTSD with ovarian cancer? And again, the literature is a bit limited, but there are some kind of early indications. One is that folks with a history of mental illness or prior history of trauma or post-traumatic symptoms are likely to also experience, recurrence of their symptoms or kind of worsening symptoms with a new traumatic event as a result of their cancer treatment. In addition to that, it seems that individuals with early stage disease, that in itself may also confer a heightened risk for developing post-traumatic stress. And it's not exactly clear why this is, but we think that it may be related to a number of different factors. One is related to kind of some changes in body image, definitely hormonal changes, treatment-related side effects, the fact that relapses can be common, and also that expectations may also vary depending on the age and prior experiences as well. That may explain some of what we see in terms of early stage disease and PTSD. So in thinking about PTSD, cancer and PTSD, I think one common question that we get, and a way that Anna and I thought would be helpful to kind of frame this talk, would be to kind of think about, in what ways does cancer or can cancer kind of predispose somebody to experience post-traumatic stress symptoms, and then vice versa, in what way can post-traumatic stress also serve as a risk factor or kind of predisposition for patients possibly developing cancer. And so we're going to talk about kind of both aspects of that and just kind of think about what do we know based on just kind of the diagnostic criteria, but also in what's been observed clinically and in different research studies. So with the first question, cancer and PTSD, we know that not everyone who has cancer will develop PTSD, but that traumatic experiences related to cancer may certainly increase the risk and may serve as that initial traumatic exposure for the development of PTSD. So there have been some challenges just historically in thinking about PTSD and cancer. And I think one limitation is that when PTSD was first kind of studied and when this kind of diagnosis first came about, the population that it was initially studied in, was really individuals who had experienced war, combat, sexual traumas, and natural disasters. And so a lot of the very early literature and kind of early interventions really focused on individuals within that population. Since then, the definition for those initial exposures has certainly been broadened, but it did take a while for us, as a field to really get there and to recognize that this is, actually a very significant problem within individuals with medical illnesses in general, but specifically within individuals with cancer, that there can be a heightened occurrence of PTSD within individuals with cancer. And so that was kind of one barrier to really kind of our understanding of the field. The more that something is kind of classified as a diagnosis, there are other kind of implications with regard to attention and funding and kind of research as we think about it in general. And so I think the inclusion was a really important step to really highlighting this as an important issue and something that needs further study going forward. So prior to that kind of expansion of the initial definition of kind of a traumatic experience to kind of incorporating cancer, some of the earliest case reports of PTSD in individuals with ovarian cancer, those kind of were first published in the literature in the 1990s. And there's a group in Japan, and if we have some time towards the end, we can present you with some of those case studies as well. But in general, they found that, individuals with cancer through prolonged, repeated, multiple stressful events, that this can certainly serve as vulnerability to developing post-traumatic stress disorder and other trauma-related symptoms later in life. And that there can be both internal stressors related to treatment side effects from kind of cancer treatments in general, but there can also be external factors related to the hospital visits, follow-up exams, or other kind of complications related to certain procedures or treatments that can kind of be recurrent or repeated traumatic stressors as well. And so, unfortunately, we don't have time to go into all of the literature, but I wanted to highlight a couple of kind of the key studies in this area. So one comes out of the University of Pisa, Dr. Carmassi, who looked at post-traumatic stress and depression among adult women with ovarian cancer at very different stages of disease. And it was a small study, but an important kind of early study for just capturing, how often does this occur and what is the impact in someone's life if they do have PTSD. And so they found that in this particular study, they found about 29% of women did report a diagnosis of post-traumatic stress. So when they did questionnaires and kind of surveys, they had women kind of rank which symptoms they were experiencing and kind of classified that to determine whether they met criteria for PTSD. And of those women, they found that women with post-traumatic stress disorder did have higher depressive symptoms and a significant impact on their work and social functioning, as we would expect with this disorder. And so this really highlights the need that, this is something that we need to pay more attention to, and that we really need to focus on the traumatic burden of ovarian cancer in order to develop appropriate interventions specific to treating patients in this population. The next study comes from the University of Manchester, Dr. Gonsalves. So this was a longitudinal study. So they looked at a few different time points as patients were getting treatments and after they completed treatments, and they received a post-traumatic stress diagnostic scale. So again, kind of different questionnaires to assess symptoms. They found that in the population that they studied, about 36 to 45% had experienced post-traumatic stress disorder. And of those, it was more common to experience intermittent symptoms, so kind of symptoms that occurred and then later resolved. And then a smaller proportion experienced persistence symptoms that kind of lingered on even further across multiple time points throughout the study. So there are some limitations to this study. Unfortunately, there was some missing data, so not everybody was able to complete all of the assessments. We think that may be related to just kind of the burden, the burden of just illness and treatments in general, that it's a lot to ask people to take on, having to fill out additional paperwork in addition to kind of getting treatments for their illness. And then the second is that it was a self-reported questionnaire. So these were not individuals who were kind of formally assessed by a mental health professional, but they were kind of self-reported symptoms. And so that's kind of a couple of limiting factors to that study, but still really important data for us to know.
And now moving on to consider the question from the other side of it. So after having seen in what ways does an experience of ovarian cancer inform someone's development of PTSD, now flipping that question and starting to look at in what ways does PTSD, whether it's a lifetime experience of diagnostic PTSD itself or traumatic experience, how does this in turn impact an individual's development or experience of ovarian cancer? So research does exist to indicate the role of chronic stress in cancer genesis across diagnoses. This has been seen both in terms of tumor growth and initial development, as well as the repression of the immune system to be able to fight it off when it arises. So one perspective on this is PTSD can be seen as one iteration of chronic stress, particularly lifetime experiences of trauma or PTSD. As without treatment, triggers may cause an individual to have disproportionate stress responses to stimuli for years at a time. So over a lifetime, the physical and mental impacts of these stressful exposures can absolutely accumulate. With the current research that exists, there is no linear takeaway. It wouldn't be possible to say that PTSD absolutely causes ovarian cancer. As was mentioned earlier, many people have PTSD and don't go on to develop ovarian cancer, and vice versa. But understanding the reciprocity in terms of cause and effect can really help deepen the understanding of the mechanisms by which this happens. And on the next slide here, so in this one study from Roberts et al., it highlights the relationship between a lifetime experience of PTSD and later developing specifically ovarian cancer. In this study, results showed women with strongly manifesting PTSD symptoms, so ones that were drastically impacting their quality of life and rose to that level. From a range of life causes. They had a twofold greater risk of later developing ovarian cancer versus women with no trauma exposure at all. The writers of this article provided some possible mechanisms through which this could occur. One perspective is the activation of the sympathetic nervous system in response to a perceived stressful event, so those stressful stimuli, can lead to a cascade of stress hormones and then resulting physiological impacts on the body. In animal models of ovarian cancer, this activation cycle acts as a tumor growth accelerant. However, animal models can absolutely be limited in our understandings. And so when we shift over to human studies that currently exist about ovarian cancer, some studies have definitely shown a link between trends of chronic anxiety and depression being linked to moderately elevated risk of ovarian cancer. So again, PTSD can represent heightened forms of this kind of distress. And one interesting point of note with Robert's study was that even when they took the results and adjusted them for ovarian cancer risk factors, such as genetics or life experiences, or even health behaviors specifically related to post-traumatic stress disorder, this only slightly dampened the strength of the association, which suggests that there's something specific about the PTSD mechanism, whether it's biological, hormonal, or immune, that may inform the relationship of later developing ovarian cancer.
So now that we've given you an overview of what is PTSD, how does it occur in ovarian cancer, how do we screen for it, now we're going to focus a little bit on treatment. And so on the next slide, as we've mentioned, unfortunately, PTSD is not a disease that responds, for some patients, it's not a disease that responds very well to medications, but that doesn't mean that medications are off the table. We do try to treat symptomatically for those patients with severe symptoms who are interested in medications. And so usually, we try to treat to target. So if somebody has really severe depressive or anxiety symptoms or a lot of difficulty sleeping or nightmares, we may recommend certain medications to help with those symptoms. But really, the key intervention here is really psychotherapy and counseling. There, have been a lot of really great evidence-based approaches that have been shown to reduce symptoms and distress and to improve function in individuals with post-traumatic stress disorder. And so there are, very effective treatment strategies. And so something to think about is that it does, psychotherapy is available both on an individual level and in a group level. We generally do recommend that folks will start out individually working kind of one-on-one with a therapist or counselor, either a social work, psychologist, whoever is available and whoever you feel like is a good fit for you. There are also a lot of, different types of therapy that can be helpful. So CBT is probably the one with the highest evidence-based specifically for post-traumatic stress disorder. But there are a lot of other, exposure therapies and narrative therapies that I think we'll get into a little bit more on the next slide as well.
And in addition to the therapeutic support that can be offered in more structured settings, so for example, psychotherapy, talk therapy, or even in working with a psychiatrist, there are absolutely treatment strategies that are effective and a person can do and learn themselves. So I think one really big way that we look at this and work with patients about is around planning. So identifying triggers and planning accordingly in daily life can actually be an opportunity for empowerment and control in a situation that can so often lack it. So specific examples of how planning can be used in a therapeutic way when it comes to trauma or PTSD symptoms is for example, if we look at commuting, which we mentioned earlier, where if a person observes a really strong stress response or trauma response to passing certain buildings or going certain places, or there's something about the commute itself that starts to bump up that stress reaction, taking very concrete steps to minimize stressful drives, arrive with extra time, change routes as needed, or not pass certain triggering places. Or another example, if you have a long day ahead, you have kind of a long day of scans or treatments, making sure to build in breaks or even short walks to sort of catch your breath and ground yourself with some of the tools we'll touch on next. Even when we think about planning for triggers in terms of treatments themselves, so we mentioned Doxil earlier, is that bright red medication that will be given to folks sometimes. If there is a strong traumatic response associated with that, just thinking critically in ways maybe it can be covered up during treatment or working with your care team about ways to minimize exposure to that bright stimuli. And then in terms of coping skills, it can be an incredibly impactful and useful way to manage symptoms as they come up. Because many triggers, they can't be planned for or avoided. And so what does one do when they come up? Starting with even simple breathing exercises, be it box breathing or other examples that might work for a person, can be enormously helpful to ground a person and bring them back to the present when they notice a panic or PTSD response coming up. Tools such as guided imagery, practicing mindfulness, whether it's something like taking a walk or even a guided mindfulness meditation can be helpful. Another coping skill that some patients find helpful is really working with sensory activities as a means of grounding. So for example, when we think about the five senses, some folks might find helpful a playlist of specific music that helps them feel calm or reminds them of a more peaceful, happy place for them. Or another idea is when it comes to tactile crafts. So for example, whether it's knitting or coloring, something as a sensory reminder to stay in the present, even when the stimuli start to feel overwhelming.
And so when we think about, who benefits from treatment, I think the answer to this is pretty broad. It's really patients across the spectrum. So folks with really severe symptoms who have PTSD and those with also trauma-related symptoms or triggers or heightened anxiety. I think, all of those patients can benefit from treatment. And I think it's really a matter of identifying people early and getting people in to treatment and recognizing that, there can be a lot of barriers, including the illness itself. But I think working closely to get to know and understand the individual and what's distressing for them, and kind of problem solving related to kind of how best to access services as well. So as we'd mentioned, a major barrier is kind of self-identification, or just making sure that we ask patients and individuals about their experiences, particularly those who have been in the hospital or who have had significant medical complications. It's important to screen for traumatic experiences in those settings as well. And so the treatment effectiveness may be impacted by the types of PTSD symptoms, as well as whether the patient has intermittent symptoms or persistent presentations, as well as kind of the severity of their symptoms and how often they occur. But definitely something that can be tailored on a personal level, depending on kind of what the patient is interested in or what they've found effective in the past, and kind of what they have access to. But something to think about going forward.
So we did provide some case studies to look over and just kind of get a sense of with the both clinical criteria, but also the ways these very much present in life. However, being mindful of the time, would love to hear from our OCRA counterparts if this is a good moment, just for a few minutes of questions from the audience.
Thank you. That was a great presentation. It doesn't look like any questions have come in yet. Maybe we'll just pause for 30 seconds and see if anyone comes in. And we do only have 4 minutes. So I don't know how long your cases are, but if there aren't any questions. Oh, one just came in. It's more of a comment. Cynthia says, I was never diagnosed with PTSD, but recognized myself in many of the symptoms listed. What helped me were several of the potential treatments you've listed, especially mindfulness, meditation, breathing, exercising, crafting, and getting out in nature. Erin asks, do we have any idea what the specific mechanism is between ovarian cancer and CPTSD?
Great question, Erin. I appreciate you asking. And I think as we were looking at some of the research around this presentation, and particularly considering that PTSD is oftentimes such a contextual diagnosis that comes up, it doesn't necessarily happen after one event, but it can absolutely happen after a lifetime of exposure to stressful events. I think there's still very limited research about the specific mechanism between ovarian cancer and complex PTSD, or the CPTSD that you mentioned. But back to the piece of, in the sense that chronic exposure to stressful stimuli can absolutely reinforce development of, disruptive illnesses across the body. I think it's an area of a lot of growth and research hopefully coming up.
Thank you. One more question is, can you talk about how psych meds are affected by chemo? It's a slightly different topic, but it's a very interesting question.
Sure. So when we think about psychiatric medications, working at a cancer center, we do think about the medications that are, one, most likely to be effective, but also have the least number of side effects, as well as the least risk of interacting with different medications. And it's important to have, really clear communication between the mental health team and the oncology team, so that we're aware of what each one is using, and so that we don't use medications that are going to interfere with treatment. And that said, there are a lot of, antidepressants, as well as other medications to help with anxiety, PTSD, and kind of nightmares, things that can be safely used, but we would want to do so in coordination with the oncology team.
Thanks, Stephanie. All right, I think we will end it there. It is 1:59. Thank you for a terrific talk. Xenia put in the chat here, and great point. We have a wonderful,
thank you, Xenia.
wonderful programs here at OCRA, led by Sarah. Sarah, is there anything you want to mention about some of our groups and activities?
Sure. So we do offer a variety of different types of support sessions through our Staying Connected program. Everything is accessible virtually, so you can join from home or wherever's convenient for you. And Xenia was mentioning that we have Express Yourself, which is our an expressive arts program, one of our monthly community building activities, where we come together and work on a collective or an art project together that's assigned per month, and also combined with discussion. And then we also have a book club, which is, a similar sort of community building activity that takes place monthly, plus our weekly support sessions. So we encourage you to take a look at our resources at ocrahope.org, and we would be more than happy to welcome you to any of our programs.
Thanks, Sarah. Okay, and Anna, thank you. Stephanie, thank you for a wonderful presentation. That was great.
Thank you
really
so much.
Appreciate your time. And thank you all for joining us.